All right, guys, we're back for our next session. All of us throughout this panel, throughout this 24-hour session, have done hundreds, if not thousands, of surgeries. And we all have successes and we all have failures. But we learn more from our failures than we do from our successes. And Thevendran is going to actually launch us through this next session to talk about the things we've learned from some of these tough and challenging cases. Gal, take over.
Thank you, Selene. Good morning, good afternoon, good evening to all of us, all of you out there watching this global town hall. It's really a privilege for me this evening to host and moderate this session, which Selene has said really pivots on things that we learn using the in retrospect, things that we reflect on and hopefully make our practice better. And to make this session as interactive and to make it out to be what it is, I have three panelists, good friends and reputable experienced foot and ankle surgeons from the Asia Pacific region. And without any order, introducing to you Professors Masato Takao from Japan, Professor Yeap Juan from Malaysia, and Professor Chayanin Angthong from Thailand. Three gentlemen, foot and ankle specialists from their own countries who will tell us about cases that have really carved out their experience and allow them to reflect on things that they could have done better. We'll have about 15 minutes for each of these cases. And to begin the sequence of case presentations, can I introduce you to Professor Masato Takao with his first case, on how he would have done things differently for his case. Masato, over to you.
Yeah. Thank you. So first of all, thank you very much to invite me. It's my great pleasure to be here as a member of this team, good team. So I'd like to talk about my difficult case. So it is a shame and difficult job to give a lecture about my failure case in such a public place. So, but I hope my suffering experience will help you a little. I'd like to talk about a case that taught me so much. I have no disclosure. Patient was a 59 years old man. 2 years ago, he had spinal surgery.
We can't see. Yeah? Masato, we can't see your presentation.
Is there any problem?
You'll need to screen share.
Screen check?
Yeah.
Oh. Can I see my presentation?
Yeah, we can see it.
Yeah, you can? Okay, go ahead.
It's okay?
Yes.
Yes.
Okay. So, a patient was 59 years old man. 2 years ago, he had a spinal surgery for both the cervical ossification, posterior longitudinal ligament, and lumbar spinal stenosis. After surgery, he became a irreversible bilateral drop foot. He visited me in a wheelchair to hope taking plant-grade gait and live barefoot at home. As you know, Japanese people is living barefoot at home, and almost patients dislike to use troublesome and unclean braces at home. He also hoped to take plant-grade feet and live barefoot at home. I checked the MMT of 9 muscles to work as flexor, extensor, inverter, and everter for hindfoot motions, but all muscle strength was lost. So I gave up to perform tendon transfer and recommended him ankle fusion. By the way, in Caliphas, our treatment concept is return to social life and sports activity as soon as possible. To realize this concept, we introduce accelerated rehabilitation after surgery as long as it is possible to do. Accelerated rehabilitation's goal is return to ADL and sports activity in a minimum time period, and the maximum physical integrity, which was lost. This slide shows another patient of accelerated rehabilitation after right ankle fusion. By using the PTB brace, not only walking training can be started from an early stage, but bilateral simultaneous surgery is also possible. His left drop foot was so severe that it couldn't be corrected manually. Accordingly, I performed arthroscopic fusion to his right ankle and open Blair fusion to his left ankle, and applied accelerated rehabilitation after surgery to use bilateral PTB brace. Of course, on the other hand, I knew he had several risk factors: stable myocardial infarction, past surgery for lateral neck fracture, stable hypertension, and BMI over 40. BMI over 40 is the only serious risk factor. It should not be ignored. But stupidly, I ignored the problem of BMI 41.4. 5 weeks after first surgery, I found infection around the medial screw heads on right ankle and breakage of a plate of left ankle. So I did second surgery to remove the medial screw and add one more lateral screw on right ankle, and to replace a plate to screw on left ankle. However, 2 months after second surgery, the infection on the right ankle recurred, and the left ankle became a delayed union. So I did the third surgery. On right ankle, I did debridement and fill antibiotic cement, external fixation, and negative pressure wound therapy. On the left, I patiently waited bone union. 3 months after third surgery, it was happy that right ankle's infection signs was gone, but there remained no union on both side ankles. Fortunately, at 6 months after first surgery, his BMI fell below 30 on a hospitalized diet. So I performed 4 surgeries for talocrural and talocalcaneal fusion using finned intermediary nail on both ankles. 3 months after fourth surgery, it means 9 months after first surgery, bone union was obtained, and he recovered to walk with support of cane and live with barefoot at home. Several papers have already reported that high BMI adversely affect postoperative results. In total hip replacement, patients with BMI more than 35 was 4.42 times higher rate of dislocation after surgery than those with BMI less than 25. And high BMI is also associated with superficial infection and poorer clinical score and poorer statistics scores. Almost of you know that the high BMI is one of the risk factors of surgery. Then, why did I ignore the problem of high BMI? This slide shows percentage of obesity. The highest rate of obesity is in the Republic of Nauru, which accounts for 60.7%. In most Western countries, obesity accounts is 20 to 40% as a common condition. And that is why obesity is already recognized as a risk factor that cannot be ignored in Western countries. On the other hand, the rate of obesity in Japan is only 4%. It is not so popular. And it is not as problematic as diabetes and smoking when performing surgery. However, I learned from this case how dangerous high BMI is, and I changed my treatment policy and performed surgery after less than 30 BMI with proper diet and exercise. and if it is unavoidable to perform surgery on patients with high BMI, apply slow rehabilitation with careful follow-up. It was lucky for me that this patient is a gentleman, has a strong heart to overcome this misfortune, and has a good relation with us. But I say again, high BMI is a terrible risk factor that should not be ignored. Thank you for your attention.
Thank you very much, Masato. I think that's a very interesting case with a lot of learning points. EJ, I'll hand over to you for first set of questions. Anything you'd like to ask?
Yeah, I saw Malaysia right below on that graph, and Thailand as well, but I didn't see Singapore. So if we had that low BMI operating policy, I think our operating rooms will not be that busy, because definitely we have to operate on sometimes all these obese people. So it was very interesting what you did there, and I think in your setting, I think the rehabilitation, as what you were mentioning, you did pretty fast. But when I don't know, I mean, when you do bilateral surgery in the first instance, do you not take them through rehab a little bit slower? Was there any external protection with your fusions and things like that?
Yeah, in Caliphas, if the patient hope to do the bilateral surgery, so I try to perform the bilateral surgery also. So minimal invasive surgery is our policy to perform in planning surgery. So this is the reason in most cases I had to use the external fixator and so on. So and I love the arthroscopic surgery. So I hoped to I tried to do arthroscopic surgery for this patient, but his left ankle is difficult to correct to the normal position. So this is the reason I perform the open surgery. Yeah. But the minimum invasive surgery is our policy to the patient.
Chayanin, do you have any questions for Professor Takao?
Yes. I used to have a case like this. It's very difficult. But may I ask Professor Takao that how about the degree of dysfunction of the nerve sensory function at the foot? In both sides, I think it may not be intact, and it is the important factor that let you have the recurrent non-union, I think.
I completely agree with you, Jenny. Thank you very much. Yes. So nerve problem is one of the risk factor. So, if the patient hope to walk in at home in barefoot, so we should try. So if the another patient is a similar patient visited me and requested me will request me to do the same request, so I would like to do the same surgery. So I completely agree with the nerve problem is the big risk factor for him. Yeah.
Yes. Because in my case, if I found the risk factors like poor sensory function or the overweight, I may use the circular frame external fixation to protect the internal fixation for a while. And I'm waiting for the healing, maybe 2 to 3 months, and then I will remove external fixation.
Yeah.
In my opinion. Yeah.
Thank you very much.
Can I ask, in Thailand, would you offer bilateral surgery at the same time? And will patients listen to you if you say you do it one at a time, or do they want it bilateral?
Yeah. Normally, I will not. In Thai people don't like bilateral operation simultaneously because they have to walk. They have to mobilize with wheelchair. Yeah. So I I will not do it normally. Yeah, that's also the culture and my practice. Yeah, I think
Professor
it's
Takao, you told us very nicely that at the end there were a lot of learning points from this, and you are now more careful with BMI in fusion cases. But has the same criteria also applied to any other surgeries? Do you also carefully select BMI as a risk factor for, say, I know, ankle OCDs or ligament recons or anything like that?
Yeah. So, do you know? So, do you know the small restaurant in Japan? Small restaurant is every small restaurant has over 40 BMI. So the small restaurant and some small restaurant visited me to perform the arthroscopic repair of the ligament, reconstruction of the ligament, and the PTTD and any others. But all cases, I performed the bilateral surgery because for them, short period to take the treatment is very important for them because earlier returning to sports activities is very, very important for the, especially for the athletes. So this is the reason I try to do the bilateral surgery simultaneously. So and Japanese patient is very gentleman. So they perform the rehabilitation patiently. So it is also another reason. So very gentleman there.
Thank you, Masato. That was a very interesting case. I think there are a lot of really good learning points from that, and I think we will all remember this case when we pick our patients for our next operation. Moving on, I introduce our next speaker, Professor Angthong Chayanin. Angthong is a good friend from Thailand who will tell us about his case that changed his practice and he learned a lot from. Chayanin, over to you.
Thank you for your kind introduction. Okay.
Professor Thevendran, who invited me to join this activity. This is the outline of my talk today, and this is the demographic data of my patients with lateral ankle ligament injury and instability. I have 75 patients who had the operations, and I had unsatisfactory results around about 5 patients. And I select one case from this group because I think there is some perspective that we may learn from it. I made the division for 2 cases. One case with poor condition of native tissue that I perform open ligament repair and a half of pronus longus to augment that area, but I made the revision after that because the patient get back to have the recurrent instability. And another one case is the patient with the mild to moderate. In the group with mild to moderate degree of hypovarus or PSK-was deformity, and one case need the surgery again because she had a recurrent ankle instability. I chosen this case because I think it's interesting. She was a 28-year-old female. She is a military personnel. She needs training in military program, and she presented to me with right lateral ankle instability with plus or minus my degree of hypovarus at that time, and she underwent open bone storm repair with a suture ankle with no intraoperative complication at that time by me. At post-operative period, about 2 to 3 months, she complained about the lateral ankle pain again, and but no instabilities were detected by clinical examination at that time, and I followed up her for a while. Then she lost our follow-up. And 2 years after the first surgery, she came back to see me with intolerable instability. You can see that she had obvious positive result of the anterior Dover test, and also the positive from the test of Valaskala 2 test. And she had a positive peekaboo sign as this area like a high degree of the high foot virus, and the PSK was, as you can see here, by the simulated weight-bearing pictures. And for the X-ray, you can see the plantar flexion of the first ray with the high arch as the high degree. And also the foot is turned to be like in the Wallace position. And you can see that from the MRI at this time, this is the whole area of the repair tissues that you can see it is not well organized now. And this is maybe the stump of the suture anchor. And this is the area of the repair at the first time and here. So in this time, I think I discussed with the patient that she had a recurrent instability on the lateral side, and she had no hyperligamentastaxy. So the cause should be from the subtle or low degree of the high foot virus or PSK was that I showed you. And she was agreed to have the the reconstruction of the ligament with the repair of the ligament by open bone stop repair and the suture tape fixation. And she was okay. She agreed to have the deformity correction by the dry planar osteotomy at the calcaneus to correct high foot virus, and also first ray dorsiflexion osteotomy to correct the PSK1. So this is the picture from other patient, but it is the same technique. I use the suture tape fixation to be like an internal splint, and then I repair of the bone storm type procedure by open technique. And you can see that this is the postoperative X-ray that the plantar flexion of the first ray was relieved by the first ray dorsiflexion osteotomy and the calcaneus osteotomy, which was in effort to decrease the arch height. And she was no recurrent instability or pain after the second surgery, as I know now. For the proposed pathophysiology in this patient and in the patient with the mild virus of the virus of the ankle or the high foot, I think it is the precipitating factor of the failed repair of the first time ligament repair, and it can have the repetitive injury and recurrent lateral ankle instability. It can be also the pre-existing condition. So I think these conditions should be got rid of, or should be treated in this patient to prevent the recurrent instability. And I list the proposed guideline like this. I have no enough time to dig deep about this, but I will divide the patient into the patient with no deformity or with the deformity. And in this patient, it would be like in this way that you may think about the deformity correction or the orthosis after the operation. In the high demand patient, like military personnel, I think she had a high risk of recurrent instability. If I can turn back time, I will perform lateral ankle ligament repair with the deformity correction at the first surgery. And I also analyze the patient with and without deformity for the lateral ankle instability. If we use my proposed guideline, we can restore the postoperative outcome to be close to the patient without deformity, and the difference here was not significant by the statistical analysis. And it means that if I can turn back time, I will not underestimate the effect of malalignment of the foot and ankle in the patient with lateral ankle instability. If I can treat it, I can restore the function and the outcome of the surgery to be close to the patient without deformity. And I hope this guideline and this presentation will bring the new perspective in the comprehensive management of lateral ankle instability to the audience. Thank you for your kind attention.
Thank you very much, Chayanin. Very interesting series of case and also your collective experience. EJ, I'll hand over to you as a first discussant. Any questions for Chayanin?
It's interesting the case that you presented. I was in a Davos course once, and we had a similar case that was discussed with ankle ligament instability and a subtle cavus. And that patient was just treated with a dorsiflexion osteotomy and no ligament repair. And well, they did well after that. So I think this highlights the importance of why they get the injury in the first place. The thing I want to ask you is there was no mention in your case regarding the peroneal tendon strength. Was it strong in the beginning or after rehab?
Yeah. Thank you for your question. I think at the beginning, at the first time I met her, I think peroneal tendon is not strength is not so good, but I try to conservatively treat her at first by rehabilitation to make more peroneal tendon or eversion strength already. But after that, she still have the recurrent, she still have ankle instability. So I decided to operate her at the first time. And she had no ligamentous laxity at the first time that I examined her also. Yes.
Right. Okay. The other thing that I would also, this will probably be one of those contentious things, whether she has any gastroc equinus contracture, especially with a cavus foot, and if the foot, the ankle is always plantar flex, then again, it's very likely that she gets recurrent twisting injuries.
Gotcha. She, at first time, I cannot remember, but this time she had no, I think she had no gastrocnemius tightness now. Yeah, I think. I just bring this case to ask all of you that what is your threshold to make the decision to do the deformity correction simultaneously with the first surgery as the repair or reconstruction that you like?
Okay, I think I'll...
Let's ask EJ first, and then we'll ask Professor Takao.
Okay.
So that is a question which patients will ask, and especially in private practice, we want to minimize the repetition of surgery. So I will use this less akin to how if you have a flat tire, all right? And if you come into the shop to fix your flat tire and the guy tells you your alignment is off and that's why you get the flat tire, do you just patch up the tire or do you fix the alignment at the same time? So similarly, I think this is how I discuss with my patients. If they have a subtle cavus foot, recurrent instability, then I will say, okay, look, you've got this instability, you've got a subtle cavus, or you've got a subtle gastroc and things like that. And you can address all these in the same setting without increasing your rehabilitation time, because, rather than coming back for a second procedure, should you need it later on. So then the question will be, the patient will say, my foot on the other side is the same. So why I don't have symptoms on the other side? So again, it's a chicken and egg thing. I think you have to give the patient the options. You have to discuss with them, I think, in terms of evidence, what will happen, what can happen, and so on and so forth. That's my thoughts on that.
Thank you. Professor Takao, what is your threshold for correct alignment in a patient with lateral ligament insufficiency?
But thank you very much, Chayanin. It's a nice case. So, alignment with the lateral instability is a very, very important factor. But I agree with you. But so in Caliphas, you know, so after just the lateral arthroscopic repair of the lateral ligament, so 5 weeks or 6 weeks after surgery, they almost them will return to initial activities and return to sports. But so if I add the to repair the malalignment, such as calcaneal osteotomy. So if the patient will return to sports activities maybe 4 months after surgery. It's a big difference. So Chayanin, I would like to ask you, if the similar case will visit you, so what type of surgery do you choose? Will you choose the same, or so simultaneously as the calcaneal osteotomy?
Oh, okay. If I turn back time.
I perform the same to you. Same to you.
Okay.
So partly I perform just the repair of the ligament. So, and if there is any problem, move to the calcaneal osteotomy. But you already experienced this case. So after the experience this case, how do you change your treatment plan in such case?
I will pay more attention to the demand of the patient, because at first time I thought that my patient have no enough recovery because she's lazy to go back to work. I think like that at that time. I'm wrong, because actually it is from some minor deformity, and if I can turn back time, I will approach my patient like Professor Yeap said. I will pay more attention to her demand, her feeling, her perspective, to the theory and to the outcome. And I will do the deformity correction with the lateral ligament repair at the first time. Yes.
Thank you.
Chayanin, can I just throw in a question which is a spin-off to the first question? So now in retrospectoscopy, if you see patients with a cavus deformity and you're doing a ligament recon, you always use a suture brace?
Oh, for the reconstruction, right? Okay.
I never.
Or is it a case by case basis?
For me, okay, sorry.
Yes, for you, yeah.
For me, I will offer 2 options: the Achilles tendon reconstruction by Professor Takao technique. I used to do it also, and I will propose the patient. The second option is about the suture tape fixation. If the patient did not want knee surgery to harvest the tendon, most of them will select the suture tape fixation.
Okay. What about patients with multi-ligament laxity? Do you approach them in the same sort of way as well? Same philosophy? Yep. So you will also do an osteotomy and you
Okay. I'm different to Chayanin. So if there in the general laxity, I add the artificial ligament repair. So like that Chayanin. If there is a general laxity is a very, very big problem to arthroscopic repair and reconstruction. I have several serious cases. So I agree with Go. So please add the artificial ligament. So it's an internal place. Yeah.
Okay, but Masato, would you also do a bony correction in the generalized laxity, or you wouldn't do a bony correction?
Only general laxity, I add the internal press. But other cases, I never use the internal press. It's too much. Yeah.
Okay. All right, lovely. I think we're on time for our final case. That was also very interesting. But now moving on to our final panelist, Yeap Juan, who will tell us about his case and how it has molded his experience. EJ, over to you.
Okay, let me just share my screen. Okay, can you see it?
Not yet.
How about now? Can you see it now?
Yes, I can.
Okay, I think there's a little bit of a lag here. Okay, thanks Gao and Selene for inviting me to this global webinar. To tell you the truth, I'm very sleepy right now. I don't know how Selene stays up for so long. I was following some of the lectures since I think about 8 hours ago. So I have a 60-year-old lady who complained of foot deformity since birth, and now she's having pain over her mid and hind foot. This was very early on in my career, so I used to get somebody to score them in all the AOFAS scores, and hind foot score was 43. So this is a clinical picture on the right. Okay, so as you can see here, she's got a hind foot varus. She's got a pes cavus. There's a cavo varus deformity, and I don't know whether you consider the toes clawed or is, you know, or not, but it's not the typical cavo varus foot. I don't know whether it could be a neglected club foot or something to that extent. So on examination, she has a tight tendon Achilles. The hind foot does not correct with the Coleman block. There was minimal toe movement and some mild tenderness over the ankle and hind foot joints. And she had quite weak everters. So these are the pre-op x-rays. Okay. So what to do? Anybody want to take this one? How would Chayanin, how would you approach this?
I think it's first of all I have to check her neurological status at the foot and ankle first. That I have provisional diagnosis for her is like a Charcot-Marie tooth, I think, and I have to check the flexibility of the hind foot, and I think I'm quite confident that she had the rigid hind foot already. I think so. To me, if the nerve is still okay, not so bad, and the rigidity is like this, I think I may perform the triple orthodesis, and I'm not sure that if at the ankle area I may try to after I set the foot by triple orthodesis, I will check that the ankle alignment is okay or not. If it is okay, I will not do anything more. But if it still have some tilting or something, I may add on some supramalleolar osteotomy. Yeah, and also the first ray I'm not sure. I think first ray dorsiflexion osteotomy. Yeah, I think, and also soft tissue correction, the Gaston remedialization or Achilles tendon release, and also Peroneus brevis to longus to brevis transfer. Yeah.
Professor Takao, any additions to that? Thanks, Chayanin.
Yeah, I totally agree with Chayanin. So this case shows the thoracolumbar joint is almost good, but to the calcaneus, to the teres, the calcaneus and the navicular is lower in position. So I'd like to perform the 3-joint fusion after the osteotomy of the subtalar joint. So and the maybe and aid the metatarsal osteotomy.
Okay.
Yeah.
So Chayanin just now raised a question regarding the neurological status. She's got normal sensation of the foot. As I said earlier, she has very weak toe movements, the lesser toes, very weak everters. Yeah. So Gao, anything? We've got two triple fusions.
Yeah, so I think I agree with the consensus. I think I'll get a CT and an MRI. CT to look at the quality of the joints and exactly how degenerate. But I think I agree. I think this ankle joint is salvageable. So I would try and position the heel beneath the tibia as much as possible. Of course, the salvage option here is a TTC fusion with a midfoot derotation. But I think we can salvage the ankle joint here with a triple fusion.
Right. So this was early on. I don't think I have a CT or an MRI for this patient. So these were the options that I was thinking of. Pantella fusion, Blair fusion, corrective triple, Ilizarov, PA lengthening, whether any tendon transfers, or just excise the joints, okay? Or amputate, right? So this is 6 months post-op. Comments?
Well, your wounds have healed well. That's a good start. Soft tissue status is always a concern with cases like this. That's a good start.
Okay, I'll show you what I did. So I did a corrective, tried to do a corrective triple fusion. And you can see from here, I did a TA tenotomy, a 3-step tenotomy. Okay, but you can see it's still suboptimally corrected, right? So my problem was that when on table, to me, I felt the correction was sufficient. With the tenotomy, I got up to 10 degrees of dorsiflexion with a plantigate foot. However, I think this was elucidated by Chayanin earlier on regarding the nerve supply. So on weight bearing and dynamic walking, found that the foot is not really balanced. So maybe there was also not enough correction, right? So what to do now? Redo the triple, or do together with an open TA lengthening. What about tendon transfers? What about forefoot?
So to get this straight, EJ, the problem she's having at this point is she's walking on the lateral border of her foot. Is that right?
Yes, yes.
And the forefoot is in supinatus, and she's getting pain from it. Is that right?
Just discomfort, not real pain. Remember, the first one was worse. So she has, she was hoping that she could walk a little bit better. And I don't have any gait videos, but obviously the foot is still a little bit plantar flexed, I think.
Okay. I think
so Chinese,
so I think the fusion has taken at this point. Is that right?
Yep, you can see here. This is at 6 months.
Okay. So my view is you can derotate the midfoot a little bit more through the NC joint and the first TMT joint, and you can try and get that first metatarsal down into a more plantigrade position, like Chayanin said, with a osteotomy. I think it would be a pity to take down that fusion at this stage.
Chayanin?
Yes, I think the fusion is okay in my idea. I mean the triple fusion is okay, but if this is my case, I will do the first ray dorsiflexion osteotomy because I saw in the clinical picture it still have the plantar flexion of the first ray to balance the tripod. Yes, here. And also I think I will add on the opening with supramandibular osteotomy at the tibia to correct proximally because I think you did a good job already for the triple fusion, I think. So I will correct above the ankle and turn it into more valgus that it can make the balance of the center of gravity more to let the balancing of the foot and ankle. I think if this is my case, and also to prevent the downward of the forefoot, I may do the tenodesis, like of the posterior tibial tendon transfer, like a bridle procedure. In this case, to prevent the inversion turning of the forefoot, to make it more eversion. Okay.
Professor Takao, any thoughts?
Wow, please don't ask me. It's very difficult case. So you already performed a good job. So, but so if she's not so happy, so I may as the calcaneal osteotomy and the valgus osteotomy and the metatarsal osteotomy. But it may be very difficult case for me. I'm sorry.
Okay, so I'm just going to move on. Thank you for your thoughts. So this is...
Just add to that.
Sorry?
I was just going to say, I think the calcaneal osteotomy is very useful adjunct in this, and I know several people who would do a subtalar fusion and a calcaneal osteotomy at the same time to try and get better correction. So I think that would have been useful. But yes, please tell us what you did.
I totally agree with you, Gao. I wish early on someone would have told me that, but I was taught that you can get all the correction with a triple, so you don't have to do any more osteotomies. So, but this is after the second revision, and I think you would agree with me that the foot now looks plantigrade. And these are the X-rays. Okay. So what was done? Well, I did a formal TA lengthening. I did a closing wedge lateral column osteotomy, lateralizing calcaneal osteotomy as well. And in fact, after doing all that on table, it wasn't a dorsiflexion osteotomy that she needed, but a plantar flexion osteotomy. And I added on an FHL and FDL transfer to the cuboid. So to get this.
Dr. EJ,
yes.
we had a comment. Did you have any consideration in doing a supramalleolar osteotomy or fibular lengthening?
No, I agree with you that the ankle, the talocrural angle is a bit horizontal, but at that point, her ankle joint was just about the only joint which was functioning reasonably well. I did not put up the full length X-rays, but there wasn't really that much tilt in the ankle. So yeah, so this was
Thank you.
Her at 2 years, and you can tell when you have a satisfied patient when they come in with a nice pedicure.
Absolutely.
Right.
So what was just out of curiosity, EJ, what was her ankle range of motion after all of this at 2 years?
I think she had about 20 degrees plantar flexion and about 10-15 degrees of dorsiflexion. It was enough to give her a normal gait. She wasn't going to run the Boston Marathon or anything, but she was quite happy with this. So
very quickly, just for this discussion, if you had this case again or something similar now, 6, 7, 8 years down the line, would you also throw in a calcaneal osteotomy, a first metatarsal osteotomy, maybe a supramal, as Selene has said, alongside your?
Yeah, so this is, I think I did this case, this is more than 10 years out. So I would start, again, if I could do it, I would start by releasing the deforming forces. I think when I did the osteotomies, I mean the first fusion, I didn't strip the capsules or joint pretty far enough. If you look at my incisions, they were all pretty short. And again, you know, the first thing I would tell the patient was that these complex deformities may need fine-tuning. And with such a long-standing deformity, again, the strength of the gastrosoleus complex, you know, I will probably do an open TAL at that point. And the fact is, you know, not just correcting the deformity per se, but, you know, taking into account the muscle forces. You know, it's not like your typical Charcot-Marie tooth or something like that. She doesn't have any claw toes, and you know, she's got some weakness here and there, but it's so all that needs to be taken account. And I found that the first metatarsal is actually a very important medial column support. So for me, if I had to do this, I would do what the revision, as I said, as what you mentioned earlier, Gao, a subtalar fusion. If you can't correct enough with the subtalar fusion to do a calcaneal osteotomy in the same setting, and whether or not supramalleolar osteotomy, I think that one I would probably not do at that point. Okay, so I just have to echo the words of Sigvard Hansen, where you have to make the foot look like a foot.
EJ, a comment from someone asking, do you think there's a role for doing a posterior tib tendon transfer in this case?
Okay, the posterior tendon, tibial tendon was not very strong, and that was actually compared to the lateral evertus. That I did consider doing that, but I found that the FHL was the main deforming force. If you look at how the big toe is plantar flexed, so I had to remove the power of the big toe, and that's why I took an FHL instead to balance out the evertus. So I think if I had used the tip pause and not the FHL, she may still have a plantar flexion deformity of the big toe. So yeah, I mean, I would definitely consider it again if I have to do this case all over again. But I can't really recall the main reason why I did not use the tip pause. But I think it wasn't that strong to begin with, I think.
Okay, thank you. Any other comments from Chayanin or Professor Takao for EJ's case?
Yeah. Thank you very much to show us the excellent case. Yeah, it's a very, very nice, good job. So, in the first surgery, to perform everything is very, very difficult. So the second time surgery was better for this patient, I believe. It's just my comment.
So I think that's a valuable lesson as well. I think you kind of hinted on that, EJ, that sometimes staged procedures may be the way forward for multi-plane deformities. Right. So, ladies and gentlemen, I think we've come sorry, Selene.
Actually, one more question, EJ. Somebody's asking, soft tissue balance plus Lambriniti, would it have been a powerful use in this case?
Yes, I totally agree. Yes, if I had cut off more bone, as in a Lambriniti, I think that would help a lot. The soft tissue procedures, again, I think by transferring some of the medial flexors to the lateral side, yes, in the first beginning, and also doing an open TAL, yes, that would definitely be my go-to in, you know, if I ever get a case like this again. So yeah, the Lambrinoti, I think if you cut off enough of the subtalar, you can actually take off enough of the lateral wedge. The only thing is you may end up with a bit of a limb line discrepancy,
right,
and maybe a shorter, a smaller foot, you know.
Right.
So those are, I think, things to consider in that. But yes, I think that would be a reasonable approach to this.
Well, Gao, this was a fantastic session. Thank you for all the panelists. we learn so much from each other's difficulties, more than our successes. So thank you for you guys opening up and sharing those cases. We'll take a break. We'll be back in a few moments.
Okay.